very good evening to all of you. A warm greetings from Heartlines and the IACTA West Bengal chapter. It gives me immense pleasure to welcome you all once again to our Heartline mini series on heart and lung physiology. An academic journey where we explore the rhythm between the two organs that sustain our life itself. Today's session Uh, today's session is on one of the most fascinating and dynamic aspects of cardiopulmonary function, the ventilation perfusion matching, the balancing act of oxygen delivery. So it is here within this delicate balance that the physiology meets art, where the lung delivers its breath and heart accepts it to give life to its pulse. So we are truly privileged to have with us our respected teacher, Dr. Jayanta Bhattacharya, whose clarity of thought and depth of experience in physiology and anesthesia have always been inspired generation of students. Sir, your presence with us today transforms this session into a true classroom of wisdom and reflection. To all of our postgraduate and postdoctoral students joining in, I invite all of you to listen carefully, question and reflect and take part of this discussion. So each discussion, each diagram and each clinical correlation you hear today will take you closer to the understanding of the living bridge between a ventilator and the beating heart. So let us together decode the harmony of ventilation and perfusion, the essence of oxygen delivery, and the science that keeps our patients alive and breathing. So welcome everyone once again into the Heartline Saturdays, where the learning meets life. So sir, please start the class now.
Thank you, Mona Lisa. A very good evening to all of you. I must thank the Heartlines committee who have selected me for this class. Last Saturday, we had a fascinating class taken by our beloved Onupanda. So let's start. Heartlines, Voices of Cardiac Anesthesia, and I have been assigned to deliver a lecture on ventilation and perfusion, matching and mismatching. Now, the functional unit of the lung is known as acinus, and we all know it includes the respiratory bronchioles, alveolar ducts, sacs, and the alveoli. Now, if we look at the diagram here, we can see the close proximity of the blood vessels with the air passages. And you can see the respiratory bronchioles, the alveolus here, the alveolar duct and pores, and these red ones are the blood vessels intermingled with each other. And now if we take a cross section of this and try to magnify this, we get a picture like this, which is self-explanatory, and it is showing the relationship between the capillary, the interstitium, and the alveolar epithelium. Now, ventilation versus perfusion, if this is the barrier, what we call as the blood gas barrier, on one side we have the alveolar side, which is delivering the gas, and on the other side we have the capillaries, and the alveolar ventilation is putting in the gas, and the gas is absorbed by this through this membrane, and the heart is doing the perfusion part of it, and it is gases are absorbed or are carried through by the blood to the different organs to maintain oxygenation. And the alveolar ventilation, what does it do? It delivers the oxygen, and it is taken up by the perfusion blood, and the blood removes the carbon dioxide and is removed to the lungs. That is the basic physiology all of us know. Now, there must be a matching between these two, ventilation and perfusion, as otherwise the life is not sustainable. Now, if you take this model alveolus, and this is the capillary which is bathing the alveolus, we have a tidal volume of say 500 ml, and if you multiply that by the respiratory rate of 15, you get a minute volume of 7.5 liters. But does all this volume take part in the gas exchange? The answer is obviously no, because there is the anatomical dead space, which is around 150 ml. So the alveolar ventilation effectively becomes the minute ventilation minus the dead space ventilation, and it comes to be around 5 liters per minute. What about the pulmonary blood flow? It is also 5 liters per minute, and so the ventilation perfusion ratio becomes 1. So that is an ideal situation. Actually, it varies from say 0.8 to 1. Now, you take a picture of this lung. We have the two lungs, and the situation so arises, hypothetically, that the entire perfusion is going to one lung, and the entire ventilation is going to the other lung. And the VQ ratio is still 1. But is that sustainable to life? No, because there is no gas exchange possible. And therefore, we have the importance of distribution of ventilation and perfusion. So we will come one by one. First, we take up the distribution of perfusion. Now, the perfusion is governed by so many laws, physical laws, but the mainstay or main factor is the gravity, which is determining the distribution of perfusion in the lungs. Now, we know the pulmonary circulation is actually a low pressure circuit. Pulmonary vascular pressures are low, and the pulmonary vascular resistance is only 1/6 of the systemic vascular resistance, and the pulmonary blood flow is dependent on the gravity and the hydrostatic pressure within the pulmonary vessels. These are the two determining factors which governs the flow of blood in the pulmonary circulation. Now, what is the effect of the gravity? So as someone is climbing up, he has to expend energy. And so does the blood, which is moving because of the heart pumping action. The apex of the lungs is lying at a higher level than the heart in an erect posture. And so the kinetic energy in the pulmonary artery is dissipated in climbing up the vertical height. And the pulmonary arterial pressure falls by 1 centimeter of water for every centimeter of vertical distance up the lung. That is the basic thing. Now, if you look at this picture, you see that in the apical region, the perfusion is about 0.7, while towards the base, it is about 1.29. So if this is the apex and this is the base, you have a 10-fold increase of perfusion as we move down from apex towards the base of the heart. And the perfusion is distributed more to the base of the heart because of the influence of the gravity. Now, not only gravity, there is another pressure which is known as the alveolar pressure. They also play a big part in governing the perfusion, because these are thin, low pressure vessels, non-rigid, and the surrounding tissues influence the flow through the pulmonary vessels. So if you again take this model, the three pressures, the arterial pressure, the venous pressure, and the alveolar pressure, these three pressures actually determine the flow of the blood through the pulmonary capillaries, and based on these, west has divided the lung into its zones that we have studied right from our MBBS days. So this is the picture, schematic picture of West zone, lung zones. The zone 1 is the area where the pulmonary arterial pressure is less than the alveolar pressure. That is there, and we actually do not get so much of zone 1, but we can create zone 1 by increasing the alveolar pressure or diminishing the pulmonary arterial pressure. The alveolar pressure may rise due to positive pressure ventilation, use of PEEP, and all these things. And of course, the pulmonary arterial pressure can drop because of hemodynamic disturbances. Then we come to the second zone, or zone 2, where the pulmonary arterial pressure is more than the alveolar pressure, but both these pressure are more than the pulmonary venous pressure, and we call it a waterfall effect, or cascade effect, or weir effect, or dam effect. And the flow is intermittent during systole, because during systole the pulmonary arterial pressure becomes more than the alveolar pressure, so blood flow is occurring during the systole. Zone 3, where the arterial pressure is more than the venous pressure and alveolar pressure is much less. So the flow remains continuous in this area. And there is another zone which is known as the zone 4, where the interstitial pressure comes in, and it occurs when the interstitial pressure has risen above the pulmonary venous pressure. It occurs in any condition where the interstitial fluid accumulation has happened, especially in pulmonary edema, both cardiogenic and non-cardiogenic pulmonary edema. So this is the dam that we are talking about in zone 2, and these are the what I call the water which is coming up the stream is known as the arterial pressure. The height of the dam denotes the alveolar pressure, and the venous pressure is lying below. But venous pressure have no bearing on the flow. Only the difference of the alveolar pressure and the arterial pressure determines the flow of blood in this zone 2, and this is called the waterfall effect or the weir effect. Now, what are the significance of these zones? So zone 1, as I said, normally doesn't exist, but it develops during hypovolemia, IPVB with PEEP. In zone 3, what we do is we take the wedge pressure, pulmonary catheter wedge pressure in zone 3, and zone 4 occur only during pulmonary edema. Now, if you take a scan of the lung, you can see in this picture there is a central to peripheral distribution of the flow, and this not only there is a effect of the gravity, but the architecture of the vascular tree also plays a role, and therefore we have a central to peripheral pulmonary blood flow. Now we come to the distribution of ventilation. Now right lung has a volume which is greater than the left lungs, and so it will have a 55% of the ventilation, while the left lung will have a 45% ventilation. And in an upright lung, the right lung gets more ventilation, and also in supine position. And dependent lung is more ventilated in lateral position. Now, if you look at this picture here again, the alveolar ventilation is 0.24 at the apex, and it is about 0.82 towards the base of the lungs. So again, we will have an increase of ventilation as we go from apex towards the base of the lung, but the increase is 3 times more as compared to the perfusion, which was 10 times more. And why this happens? Because you see, lung is a viscoelastic in nature, and so it acts like a viscoelastic bag. So the base sags down due to the effect of the gravity. It has a bigger base than the apex. But what is happening to the pleural pressure? The pleural pressure is much more negative in the apical portions than the basal portion, which is less negative. What are the causes of inequality in distribution of ventilation? One is the gravity, the lung is sagging down, and there is more negative interpleural pressure at the apex than at the base. What is the magnitude of gradient? Now, the density of the lung is 1/4 the density of water. So, the pleural pressure gradient in centimeter of water will be 1/4 the height of the upright lung. So, if you divide 30 centimeter, you take 30 centimeter to be the height of the lungs, and you divide it by 4, you get a gradient of 7.5 centimeter of water. So, the intrapleural pressure in the apical region is about minus 10 centimeter of water, while that towards the base is minus 2.5 centimeter of water. It is still negative than the atmospheric pressure, but the negativity is much less in the base than at the apex. That causes the distribution of ventilation. So what is the effect? Alveolar pressure remains constant. The pleural pressure is less negative at the base. The transmural distending pressure, that is the alveolar pressure minus the pleural pressure, is more at the apex, and the larger alveoli at the apex, because the more negative intrapleural pressure in the apical region causes more traction on the alveoli. So they become more distended. And there is a 4-fold volume difference between the large alveoli at the apex than the smaller alveoli at the base of the lungs. So if you see this picture, at rest at FRC, the size of the alveoli in the apical region is much larger and they are smaller in number, while the number of alveoli in the basal regions are much more, plus it is much smaller in size because of the more negative intrapleural pressure, which is adding a pulling effect on the alveoli. What does that do? You have a larger alveoli at the apical region, and naturally they are less compliant. But towards the base of the lung, we have more number of small alveoli because of the less negative pressure. And what does that do? They leads to smaller alveoli, but these alveoli are much more compliant. So if someone is taking a breath of 100% oxygen, the sizes of all the alveoli becomes almost equal to each other. But you can see from the diagram that the apical region alveoli has distended only slightly, while the alveoli towards the base has distended so much, and therefore the ventilation is preferentially shifted towards the base of the lung. So if you take this pulmonary pressure volume curve, you can see in this apical region alveoli, they are taking a less compliant portion or flat portion of the slope, while the lower alveoli are taking the more compliant portion or steep portion of the curve. Naturally, the alveoli at the base of the lung distance much more at the same point of time when the alveoli at the apical region are not so distant. So initial size is more in the apical region, the alveolar size of the alveoli, and initial size in the lower region are less. So it expands lesser, and since the pleural pressure falls more during the base, during inspiration due to the proximity of the diaphragm, as the diaphragm contracts during the inspiration, it has even a more pull effect on the alveoli of the basal region, causing it to distend more. So it expands more with inspiration. The most of the tidal volume is preferentially distributed to the smaller and more compliant alveoli at the base when the inspiration is from the functional residual capacity. What happens in lateral position but the patient is awake? Here the distribution is almost same. The lower lung will be better ventilated. The cephalad displacement of the diaphragm, the dependent side, will be stretched much more because of the effect of the abdominal viscera. So when it contracts much more. So greater initial fiber length leads to more effective contraction on that side of the diaphragm that we know from the Frank-Starling's law. Now you see again that curve, the compliance curve, I can say, the apical alveoli taking the flat portion and the basal portion are taking the steep portion of the curve. So the compliance is much higher. In the lateral position, the non-dependent lungs takes the flat portion of the curve, while the dependent lung takes the steeper portion of the curve, and naturally the ventilation goes more towards the dependent lung. And of course, the perfusion is determined by the gravity, and so the dependent lungs get more ventilated and more perfused. Now, what are the factors influencing the ventilation? So, gravity and the intrapleural pressure are one thing. Different static lung volumes, that means the volume at which the inspiration has started, and compliance and resistance of the unit. Because the airway tubes will have some amount of resistance and there will be some inherent compliance of the alveolar wall, and all these three factors determine the ventilation. So resistance of the gas and flow in the tube, distensibility of the chamber is the compliance of the lungs. So if we take these three alveoli here, you can see it is a normal alveoli, no resistance, no compromise with compliance. The second one, of course, has the less compliant lung. And the third one is a highly resistance alveoli because of constriction in the airways. And if you translate it into inspiratory and expiratory flow graph, you can see the normal graph, the graph for the normal alveoli is going up quickly, take the distance very quickly, and then the expiration starts. The low compliant curve, it doesn't distend too much. So the capacity is reached very quickly and it takes then a flat plateau and then the expiration starts. While the alveoli which has a high resistance, they take time to fill up fully and then the expiration will start. And therefore the first two types, that is the normal alveoli or a low compliant unit, are known as the fast alveoli, while the high resistant unit, we are calling it a slow alveoli because it takes time to get filled up. And here the respiratory rate comes into the picture. That's why the respiratory rate is so important. So what is the effect? The time available for the alveoli to fill up will depend on the frequency of the breathing. More the frequency, less is the time for the alveoli to fill up, or also during exhalation, it needs time. So more rapid the respiratory rate, lesser the time available for the volume exchange to occur. And you can remember COPD, slower alveoli units do not fill to their final volume, and inequality of distribution of ventilation thus sets in. So we have talked about the ventilation and we have talked about the perfusion separately. What about when we put ventilation versus the perfusion? So more ventilation at the base, more perfusion at the base, the increase in perfusion as we move from the apex towards the base is much more than the increase in ventilation. That is the thing to be understood. So VQ falls, VQ ratio falls as we go from the apex towards the base. And that magnitude is about from 3 to 0.6. So the VQ ratio is around 3 at the apical region of the lungs, while it is about 0.6 at the base of the lungs. Now, if you take this picture here, you can see the lung apex and the lung bases, and the blood flow or the perfusion is much more when it comes towards the base. The ventilation is also much more than the apex in the base. But the blood flow increase is much more than the increase in ventilation. So if we take the VQ ratio curve, you can see from the apex it is around 3, it comes towards the 0.6 value at the base of the lung. So what does it mean? The alveoli at the base are slightly over-perfused in relation to their ventilation. And alveoli at the apex are under-perfused in relation to their ventilation. That is the thing to be understood. Now, if we take this model alveoli again, you see the ventilation is going on and the perfusion is also going on. So that is the ideal alveolus, which is very rarely found, and the VQ ratio here is 1. Now, if there is a block in the breathing tubes, that is the airways, the ventilation is 0 and the perfusion is same, so it is a shunt. On the other hand, if there is a block in the pulmonary capillaries leading to that alveoli, we have a ventilation perfusion ratio of infinity because there is no perfusion, the denominator is 0 and the ratio is infinity. We call it a dead space. So dead space and shunt are based on the V by Q ratio. When the unit is perfused and not ventilated, V is 0, so VQ is 0, that is a shunt. And when the unit is ventilated and not perfused, the Q becomes 0, so the VQ ratio is infinity. And such a unit is known as the dead space or wasted ventilation alveoli. So how does this shunt and dead space affect the PaO2 and PaCO2? Now, these are the 3 alveoli that we are talking about. So in the ideal alveolus, we have the ventilation and we have the normal perfusion. And so we get in the alveolus a PO2 of 100 and PCO2 of 40 that we get normally in the ideal alveolus. But in a shunted alveoli, what happens? The ventilation is getting 0 and the perfusion is going on. So what will be the alveoli having? It will have the same composition of gases or partial pressure of the gases that are there in the mixed venous blood. So it will be PO2 of 40 while PCO2 of 45. In the dead space region, there is ventilation is normal, but there is no perfusion. So the alveoli have the same partial pressures as that of the inspired gas. If we are breathing air, we have a PO2 of 150 and PCO2 of 0. Now, if you look at this curve, in the x-axis we have the VQ ratio, and they have plotted the VQ ratio from 0 to 100. And the midpoint is 1, where it is the ideal VQ ratio that we need to have. And if you look at this picture carefully, the maximum gas exchange is occurring in the range of 0.1 to 1. So the greatest useful involvement in the gas exchange is where the VQ is 1. And the substance small change in the VQ will yield a substantial improvement in the partial pressure of oxygen, partial the oxygen content, but there is not much difference in the PCO2 level. So this is the where the PCO2 and the PO2 is taking off. This is where the ideal at VQ ratio of 1, they are crossing each other, and the PO2 you can see has gone up like this, steep portion of the curve as you can call it, and the PCO2 is not much affected from this point to that point. Now if you take that same graph again, look at that. What is the effect of dropping the VQ? There is drastic change of the PaO2 as the VQ ratio falls from 1 to 0.1, while the carbon dioxide clearance is not much affected, only by 6. This is the effect of the shunt and dead space that can occur due to the affect the PaO2, PCO2 and PaCO2. So what's the point of this graph? The lower VQ ratio region, the closer the effluent blood composition gets to the mixed venous blood, to the true shunt. And in the higher VQ region, in this region, the closer the effluent blood composition gets more towards the alveolar gas composition. The relationship between the PaO2 and the VQ is steeper and more sigmoid than the relation between the PaCO2 and VQ. So West, again, Mr. West has come in. He called the what is the effluent blood? The effluent blood is nothing but the blood which is emerging from the alveolus into the pulmonary veins. Now you look at this picture. You look at this picture. There are 2 alveoli, one of them is filled with fluid, and so this vessel is not going to have any gas exchange at all in this region of the alveoli. So if we have a gas mixture or breathing air of 21% oxygen and ventilation here is 0 liters per minute, the perfusion was 1 liter per minute, so the mixed venous oxygen saturation remains at 65% when it is breathing this alveoli. But look at the other alveoli. Supposing this does not have a 0 ventilation, it has only a minimal ventilation of 100 liters per minute, and the perfusion is still 1 liter per minute. What is happening? That due to this 21% FiO2, since 100 milliliter is coming into the alveoli, that means 21 milliliter of oxygen is coming into this alveoli to be absorbed into the blood, which will give you an oxygen saturation of about 80%. Okay. What is the effect of increasing the FiO2? The same model again has been taken, and you see if we give 100% FiO2 in this patient, what happens with the same perfusion of 1 liter per minute, oxygen saturation becomes 100%. Why? Because now that 100 milliliter of ventilation is carrying 100% oxygen. That means 100 ml of oxygen is coming, which is getting absorbed. So the oxygen saturation becomes 100% of this, the effluent blood of this alveoli. So If the hemoglobin is okay, that is 100%, then the total oxygen content will increase from 89 to 137 ml per liter. And that is the effect of increasing the FiO2 on oxygenation. So what the shunt is doing? Shunt is having only a slight fall in the oxygen content, but the drastic change, drastic fall in the partial pressure of oxygen, and the only a slight or minimal fall of the carbon dioxide content and partial pressure of carbon dioxide. Now, if you look at this again, you have the apex and the base, and you can see the alveolar ventilation that I told you. This is a VQ. The VQ ratio is 3.3 to 0.6, and the partial pressure of oxygen has from 132 here in the apex has gone down to 89 PaCO2, but the range of PaCO2 change is only 28 to 42. So what are the different types of ventilation perfusion ratio? One is a zero VQ zone, where there is no ventilation, and that can occur in ARDS, complete airway obstruction, hydropneumothorax. There are regions where the VQ ratio is less than 1. We call it a low VQ zone. It occurs during partial airway obstruction, pulmonary fibrosis because of reduced compliance, surfactant deficiency, COPD, bronchial asthma. Then we have the high VQ zone of more than 1 ratio. The ventilation is normal or high, but perfusion is reduced, and that occurs in hypotension or pulmonary embolism. And we of course have the dead space where there is no perfusion, which occurs in pulmonary embolism. Now we have learned about the physiology. And what is the applied physiology, which is so important to us, the anesthesiologist? And we are every day encountering some sort of VQ mismatch in our daily activity of manning the theater or you manning the ITU. So we must know what is happening when anesthesia is induced, what happens when anesthesia occurs in lateral position, what happens with one lung ventilation, what happens with pneumopollution and obesity, why prone position in ARDS is preferred, and what happens with various diseases of the lung to the dead space and shunt. So when the patient is supine, what is happening? There is a fall in the functional residual capacity by about 80 to 800 to 1 liter. Now, induction of anesthesia. There is a loss of muscle tone, and that will encounter another further fall of 500 ml. So, the end expiratory lung volume has already fallen from 3.5 liters to 2 liters. That is the effect of anesthesia. Now, if you see this diagram here, this patient is sitting up. He has a FRC around this. When that person lies down, the FRC has already fallen. And in the sitting position, the FRC is more than the closing capacity. And you can see the graph is the FRC line is crossed by the closing volume line at this point, which corresponds to about 65 to 70 years of age. So anybody above 70 years of age lying down will already have the FRC below its closing volume. But when the person lies down, that closing volume curve is crossing this FRC curve at about 44, 45 years of age. And here the FRC becomes less than the closing capacity. So when the patient lies down at 44 years, the FRC has already fallen below the closing volume. That is the thing to be noted. Now in this graph, you can see there are changes in percentage of lung volume and with age in the erect posture. Now the closing capacity increases above the functional residual capacity at around 70 years of age in erect posture. But when the patient lies down, it occurs at the age of 44 years. So what is the relationship of functional residual capacity with the closing capacity? So if we take the FRC, the patient is upright, then we are curved like this. When the patient has lied down, the FRC has already fallen. And when you have induced anesthesia, it has further fallen. And if you superimpose the closing capacity graph here, you will have a point where at about age of 30, the closing capacity is getting more than the FRC. So FRC is nothing but the expiratory reserve volume plus the residual volume. And FRC in an adult supine typically is quoted at 30 ml per kg. Now, closing capacity is the sum of closing volume and reserve volume. And closing volume is the volume of gas in the lungs when the airways first begin to close. So closing capacity is therefore more useful in clinical practice than the closing volume, as it can be directly compared with the functional residual capacity. So when the closing capacity is greater than the FRC, there is an impairment of gas exchange. Now you can see in this diagram, gradually in the inspiration, the airways are pulled open by traction from the neighboring alveoli and the gas is going fine. With expiration, the traction decreases. So the alveolar volume decreases. Further into the expiratory phase, the smaller airways decrease in the diameter, and the last phase, the closing capacity, is the lung volume at which the airways have completely been closed. And what happens after that? That gas which is trapped in the alveoli get dissolved, and therefore we get a collapse of the lung. So in an awake patient, you can see the alveoli of both the upper region and the lower region are inflated. While the patient, when is anesthetized, the surrounding structure has made the airways collapse, and with further increase in time, the alveoli the gases in the alveoli are dissolved, and though there is a total atelectasis of this alveoli. And anesthesia causes what? It causes decrease in FRC. There is decrease in the compliance of the lungs, and the airway pressure or resistance of the airway increases. So extraluminal pressure getting more than the intraluminal pressure, causing this collapse. So there is airway collapse. So there are zones of VQ zones. Continuous airway closure leads to resorption of the gas from the alveoli and therefore causes atelectasis. So there will be development of zero VQ zones or shunts, and the dependent portions of the lungs under anesthesia do develop shunt due to a fall in the functional residual capacity. That we must remember, that whenever we have induced, we have done some damage. We have not done the damage, but the consequence of anesthesia is there will be development of shunt in the dependent region. And what is that? Why dependent region we are more concerned? Because perfusion is still better in the dependent region. So if you take a CT scan here, you can see the scan in the awake patient and the patient when anesthetized, and you can see the areas of atelectasis creeping in. So why the FRC falls with induction of anesthesia? Anesthesia induces a cranial shift of the diaphragm and decrease in the transverse diameter of the thorax. And these effects contribute to a lower. Yes, any problem? So these effects contribute to a lowered FRC. The decreased ventilated volume due to the atelectasis and airway closure contribute to a reduced compliance, and decreased airway dimensions by the lowered FRC can contribute to the increased airway resistance. So these are the reasons why ultimately the FRC falls due to induction of anesthesia. And you can see the lower region, the alveolar, the airway are getting closed and it will be absorbed. So there is more atelectasis in the dependent portion of the lungs. So what is happening? Better ventilation in the non-dependent region and better perfusion in the dependent region, and therefore we have a VQ mismatch which leads to hypoxemia. And that is why when we give anesthesia, we need to give at least 30% oxygen and not 21% during anesthesia. Now, how to overcome this? There are two maneuvers that we usually do. That is the PEEP and the recruitment. So what does the PEEP do? PEEP open up the closed air, and recruitment increases the intraluminal pressure in the alveoli and open up the collapsed alveoli. So when the alveoli are collapsed, even just PEEP is not sufficient enough. You have to recruit the lung. Once they are open up due to the recruitment maneuver, then you can start your PEEP, and then it will keep the open airway patent and open. So how do we give the recruitment? We have to increase the peak inspiratory pressure to about 40 centimeters of water and hold it for 6 to 8 seconds. That is good enough. Now, if we are giving too much of PEEP, then again it can increase the dead space in the upper zone, because the PEEP is going to increase the alveolar pressure, which will be going more than the pulmonary arterial pressure, and so we will be getting a dead space. And in the lower rung, it can increase shunt, because it is going to redistribute the blood flow to the dependent lung regions which are atelectic. So we have to keep a balance of PEEP, what PEEP we should be giving, and we should be keeping an eye on the oxygenation of the patient. So what is the effect of anesthesia on carbon dioxide elimination? It increases the dead space, elimination of carbon dioxide, but it can easily be corrected by increasing the minute ventilation, but it is not significant clinically. What happens with anesthesia in the lateral decubitus position? In the lateral decubitus position, you can see the non-dependent lung is taking the flat portion of the curve, while the dependent portion is taking the steep portion of the curve. Right. So once the lung the patient gets anesthetized, they change the position. Now the non-dependent lung takes the steep portion of the curve, and the dependent lung takes the flat portion of the curve. So what is happening? Again, VQ mismatch. So ventilation and perfusion are more dependent to the dependent lung. Fall in FRC moves the lungs to a different area in the compliance curve. The non-dependent lung is better perfused, better ventilated. The dependent lungs get better perfused. The result is a VQ mismatch and hypoxemia. Now, why does this happening? Because FRC is getting reduced. So the induction of anesthesia, number one. The use of neuromuscular blocking agents causing diaphragmatic paralysis. So there is more pressure of the abdominal contents over the diaphragm. Pressure of the mediastinum. You can see here the mediastinum is facing over the dependent lung. The surgical compression or retraction that is part and parcel of surgery, and in open thorax surgery, you have to keep an eye on the hands of the assistant and the surgeon also, and keep on reminding them that please do not give so much of compression over the lungs. The patient is getting desaturated. That almost everybody has done that. Plus suboptimal positioning, you can see due to the positioning and the supports here, the dependent lung gets compressed. So all these factors reduces the FRC of the dependent lung. So what happens when anesthesia is administered in lateral decubitus position and there is one lung ventilation? So in one lung ventilation, you can see the upper lung is already collapsed, but the perfusion is still going on. So there is impaired oxygenation, and in the dependent lung there is atelectasis, and the ventilation is therefore reduced, but the perfusion is more, and therefore there is impaired oxygenation and there is development of shunt, and these causes a low VQ zone. So shunt in the alveoli, first we take two lung ventilation.
হ্যাঁ তুমি ততক্ষণে পুজো করে নাও।
So what is the fractional blood flow? In two lung ventilation, supposing we have 40% in the upper lung and 60% in the lower lung. Now, if there is a 10% shunt and we have a 5% shunt in each lung, then the distribution is 35 to 55%. What is happening when we are doing a one lung ventilation now? The perfusion is still 35% in the upper lung and in the lower lung is 55%. So 35% is totally shunt plus the 10% shunt here will give a 45% shunt. Is this true? Actually, it does not happen like that because of phenomena that God has given, that is the HPV or the hypoxic pulmonary vasoconstriction. That diverts the blood from the hypoxic zone to the more ventilated areas, and therefore we land up with a shunt of about 27.5%, and but there is a shunt of 17.5% in the upper lung or the collapsed lung. That has to be there. So if you are now ventilating, if FiO2 of 1, that's 100% oxygen, in both lung ventilation you will have a PaO2 of 400, while here we will have, due to the shunt, only a PaO2 of 150 millimeter of mercury. So what is HPV? Now old anesthetics at more than 2 Mach inhibited the HPV and worsened the shunt. Modern anesthetic like the sevoflurane or the isoflurane or desflurane that we use nowadays, at 1 Mach they do not reduce the HPV. But if you are using a vasodilator, it will worsen the HPV. And so will conditions of hypothermia and alkalosis. They worsens the HPV. And any inhibition of HPV will increase the shunt and worsen the hypoxemia. So how do we manage a case of hypoxemia during one lung ventilation? You start with an FiO2 of 1. You give a dependent lung peak to avoid atelectasis. You ventilate at FRC as the pulmonary vascular resistance is minimal at this point. And you can also give CPAP in the non-dependent lung. So if you see this curve, you can see both at residual volume and TLC, that total lung capacity, the pulmonary vascular resistance are higher, and it is minimal at FRC. Okay, so the idea is to ventilate at FRC. That is nothing but keep the lungs slightly inflated, not much, which is going to hamper the surgical process, but slightly inflated by using a CPAP in the non-dependent lung. What happens with obesity? Now, you can see in this picture, the normal tidal exchange is way above the closing volume. But when the patient is obese, the tidal volume is already in the region of the closing volume. And once you anesthetize these obese patients, the tidal exchange is going below the closing volume. Not the tidal exchange, but the functional residual capacity. So there will be hypoxia. The tidal volume falls within the closing volume. There will be atelectasis, and therefore in obesity there is increase in shunt. And to overcome this, you require more than 6 centimeters of teeth, and you may need to give 8 to 10 centimeters of water pip. And during recruitment, the inspiratory pressure, the PIP, should be around 55 centimeters or more, water, or even more is needed to open up the collapsed alveoli. What happens with pneumoperitoneum? Everybody is familiar with this picture. The diaphragm is pushed capillate, and that causes reduced FRC and therefore atelectasis. But we do not get so much of hypoxia in laparoscopic surgery, and there is a reason for it. The interesting thing is that the HPV is increased by carbon dioxide. So blood flow is redistributed to the ventilated zone and shunt is reduced. So the arterial PO2 is not affected much by pneumoperitoneum. And this does not happen if we are using air instead of carbon dioxide or any other gas than carbon dioxide. The HPV saves us with carbon dioxide. In prone position, you see the vertical pleural pressure gradient is lesser in the prone position. The mediastinum, which was pressing over the dependent portions of the lungs, now rests on the sternum. So it is not pressing on any lung tissue at this moment. So there is a more even distribution of the inspired gas or ventilation. So there is a better ventilation perfusion matching in prone position, and therefore it is helpful in ARDS to improve the oxygenation. What happens in different diseases? You see, in pulmonary embolism, hemorrhagic shock, or COPD, there is more of dead space ventilation. While if there is atelectasis or there is pulmonary edema, where there is increase in the alveolar fluid, or there is consolidation, there gives more to shunt. Dead space is increased, primarily will affect the carbon dioxide inhalation, because no perfuse and no alveoli is getting perfused in dead space. And increase in shunt primarily affects the oxygenation. Now, what are the causes of this VQ mismatch in cardiac anesthesia especially? Not much, because still there is atelectasis because of lung collapse, especially in the dependent lung, which reduces the ventilation in areas of blood flow, areas with blood flow. There is extravascular lung water. The fluid accumulation occurs in the lungs and can occur after the cardiopulmonary bypass and interfere with the gas exchange. Changes in cardiac output. If there is a low cardiac output, can reduce the perfusion to some lung areas. If there is a high cardiac output, might increase the perfusion to poorly ventilated areas, which increases the VQ mismatch. Positive pressure ventilation, which we have to do, can cause over distension of some alveoli and collapse of the other, altering the normal VQ ratio. Physiological changes are there. Anesthesia itself can lead to changes in respiratory mechanics and can cause the body to shift the perfusion. So what are the effects of VQ mismatch? hypoxemia, hypoxemia, and hypoxemia. Plus, there is increased water breathing. The hypoxic pulmonary vasoconstriction is triggered, but there is a possibility of VLI, ventilator-induced lung injury, and all this will contribute to an impaired recovery. The assessment, how do you assessment the VQ mismatch? The multiple inert gut elimination technique, pulmonary artery catheterization, and electrical impedance tomography. And you do not ask me anything about those things because I don't have any idea on those. But you have to give a positive end expiratory pressure, you have to do the oxygen therapy, and of course, positive inotropic agents and vasopressor to maintain the perfusion. The take-home message. What does the VQ of 0.8 means? It means that for each unit of blood flowing into the lungs, 80% of that volume of air should be ventilating the lungs. That means if 100 ml of blood is going to a lungs, then the lung should be ventilated by about 80%, 80 milliliter of gas. So gas exchange requires both ventilation and perfusion. Perfusion is 10 times more in the dependent regions. Ventilation is 3 times more to the dependent regions. The fall in the ratio as we go down from lungs is from 3 to 0.6. No ventilation, only perfusion is shunt. No perfusion, only ventilation is dead space. Lot of imperfections are seen even in healthy lungs. Obesity, anesthesia, pneumoperitoneal lung ventilation affects the ventilation perfusion distribution and is affected by the different disease states. You have to understand the physiology, and if you do not understand the physiology, it becomes a hinder to your management effort. So what is the aim? Our aim is to prevent all these things during a procedure. Our aim is to maintain the oxygenation, which is acceptable. At the same time, we must prevent ventilator-induced lung injury. So for that, you give a low tidal ventilation, hemodynamic optimization has to be done, positioning has to be optimized, and you need to give appropriate peak. Thank you very much. Shubho Kali Pujo. Happy Deepavali.
Thank you so much for the excellent presentation. So fast and so detailed presentation. And there's one question in the chat box, that is how to add CPAP via conventional anesthesia ventilators. Sir, can you answer this?
Hello.
Yes, sir. There is one question. Somebody has asked that how to add CPAP via conventional anesthesia ventilators.
No, actually with conventional anesthetic ventilators, you cannot do that. You have to have either another anesthesia machine for that, or you need to have a CPAP machine. The CPAP machines are now available, which are usually used by these persons who are having OSA. Those machines can be used to give the CPAP.
Or, sir, they can have a different source of oxygen, which can
Yes.
be connected with
Another source has to be there.
yeah,
Whatever need.
either oxygen cylinder
Yes.
So any other questions from anyone?